All right, so May 2026 marks the 77th annual Mental Health Awareness Month with a focus on reducing the stigma and strengthening community support. So, Mental Health America's 2026 theme is More Good Days Together, emphasizing collective well-being, with the key initiatives being sharing stories, wearing green, and accessing various resources and tools. And with that, we have two wonderful programs here today to have a conversation on and a question answer session on what are some considerations, what are some things we should think about when starting a behavioral health mobile clinic. And we have two great programs here today. We have Tracy Goldbach, the Director of Clinical Operations at Ridgeview Behavioral Health Services, and Kim Miller, the Director of Mobile Health Clinic at Ridgeview in Oak Ridge, Tennessee. And we have Jonas Cooper, who's the Assistant Director of Child Development at Community Action Council in Lexington, Kentucky. And so thank you for all three of you for joining us in this very important conversation today. And hopefully some of our listeners will get some nice pearls of wisdom and nuggets and not if they're looking to start a behavioral health program or they're looking to enhance it. So welcome to all three of you.
Thank you.
So would you like to share a little bit, Tracy and Kim, first about your program at a high level, how long you've been in operations and some of the services that you provide?
You want me to go, Tracy?
Yeah, I'm going to have you go ahead.
Okay. We have a mobile unit, and we are funded through Project Rural Recovery through the Tennessee um, Mental Health Substance Use Department of Mental Health Substance Use. We go to 5 different counties in that were identified by the state as counties that needed a little extra help, and we provide basic primary care and behavioral health care, which includes substance use. It includes med management for psychiatric meds, therapy, case management. We also have a peer support on board. Um, and we just try to encompass all of their needs from a very rural standpoint. Um, they may or may not have access to any of those in their area. So we drive, I think our shortest drive is a half hour and our longest drive is a 2 hour one way to provide services to people who just don't have access.
And because we are grant funded as well, we don't deny services to anybody. We don't require any kind of insurance or any kind of payment. So that's also been very nice.
Thank you very much. And Jonas, would you like to share a little bit about where you are in your mobile health program journey?
Yeah, I'm happy to share. So I work with Community Action Council. It's part of the National Community Action Partnership Network that you'll find in most places. Um, I love where I work. We serve over 13 counties, technically more, but we're officially have people and buildings in at least 13 counties here in Kentucky. And so we've kind of follow I-75 and then east. And then for anybody who's not super familiar with East Kentucky, it's rural, mountains, it's Appalachia. And so um, East Kentucky is very poor. And so when you think about the mission of Community Action Council, which is to alleviate and reduce the symptoms and the causes of poverty, we fit right in and we're super enthusiastic about what we do. Um, we've run a number of programs that benefit the groups that we serve. The one that I'm directly involved in is with our Head Start program. That's why my title says Child Development in it. And so within that program, I serve as the Early Intervention Director, among a few other things. But if there's any needs for disabilities or services or therapeutic interventions, it usually runs through me and my team. And so the reason that we've been looking at a mobile behavioral health unit is for a few reasons. A couple things fell in place. We have a Head Start program, so we have school buses already. And we have school buses that we can't use anymore because they've been outdated or they don't meet a certain criteria that works for federal standards to meet our funder requirements, but they're still completely safe to drive and everything like that. But they're just sitting. And so we were talking about how can we best utilize what we have. Um, and we were thinking and brainstorming and talking about, well, if these buses are just sitting here and we can't transport children in them, what can we do other than just use them as moving stuff from here to there? And so, if anybody was in the part one of the strategic group last week, there was a comment made talking about community assessment and knowing what uh, your community needs. And so we do a community action as a whole does a community assessment survey um, every 3 years. We renew it, but every 5 years we do a whole brand new thing. And so what we found this last year that we did ours, mental health was at the top of everybody's concerns and what they're saying that they need help with. And not just mental health, but family mental health and children behavioral health. And so we know that there's a need there, and the people that we serve want that. And so that's why we've decided that we're going to try to put our best foot forward in our efforts into getting this behavioral health unit up and running so that we can roll out to not just the kids that we serve in our Head Start, but all the counties and kids, because there's just not much out in East Kentucky.
So we border you on Eastern Kentucky, my area for the mobile health clinic. We are right on the border in three of our counties of Eastern Kentucky, Tennessee. So I think that's a great idea. I think it's absolutely needed. Um, and just to get it out there to the public so that they know that it's there. I think sometimes when they are looking for services and they can't find any, it it becomes very um, hard for them to even press forward to look for more. They're just kind of like, oh, well, there's nothing here, and then they just go on and they don't try to expand.
Yeah, and we found in our focus plans, at least initially anyway, is going to be that pediatric behavioral
Mhm.
health. Um, and so, because if anybody's familiar with the hierarchy of needs, um, we're talking about families who don't may not have running water even. And
Mhm.
so, if you're drinking dirty water and living on a dirt floor, which is not an exaggeration for some of our communities, um, mental health is not necessarily at the top of your list.
Right.
And so that's why we partner with, other organizations and the programs that we do. But one end that we have found to kind of branch that gap in between need and recognition of need is childcare facilities.
Mhm.
Because these COVID babies are something else. And so, there's a lot of challenges there. And so we have an in with childcare providers all over the place, and that's what we specialize in with Head Start. And so, um, a lot of times, parents with young children, even, and we're not even talking about school, we're just talking about preschool. If their child is acting out and having trouble for whatever reason, whether it's something clinical or whether it's a behavioral health, whichever it is, if they get kicked out of that preschool, then that family has a whole other problem, and then you're worried about the welfare of that child. And no child care facility wants to be in that situation anyway. And so one of the ends we found is working with child care places to, I guess, kind of support their staff. And what we found is too that when we support the staff have the relationship with the families, and they recommend and talk, and that's how we find our in with the family mental health and not just the single individual child. So we have a lot of pieces falling in place. It's just a matter of putting them together, I guess.
So, Jonas, thank you very much for sharing where you are in your journey. And it sounds like there's so many key elements you have figured out with your program. In this conversation today, as knowing where you are today with your program and where you can kind of visualize where you would like to be, what are some of the questions that perhaps you would like to ask our Tracy and Kim here at Ridgeview that would help you to get ahead in those next steps?
Yeah. So initially, I have a few. I'll start with funding because that's usually people usually wants to know about money. Um, Part of the idea behind this too is to structure it in a way to where we can at least have the program self-sustaining, and we're not having to continually find other areas of revenue and income to support the bus. And so while we're lucky that we have lots of Head Start money, we can't really use Head Start money because if we do, then that bus has federal interest in it. And in any income that that bus makes, even minimal, just to cover gas to get places, we have to report that, and then that gets deducted from, our overall award. And so it's a little bit more complicated than just using grant money that we already have. And so I'm curious if there's been a group or a certain area of the field that have been really receptive to mobile behavioral health.
I don't even know where to start with that answer. We have always been grant funded, and our grant, we were very lucky it has been extended. Um, there is a need with all the data, and I think the state sees the need. So the state is the one who granted us. That is correct, right, Tracy? It was the state. It came down. So they saw the need. Um, the hospital, the ER reduction, people becoming um, or just seeking services, and overall, I think we have some physical um, measurements, indicators that we use to provide our data. Um, so the state has just been we've just been very lucky in the state recognizing the need.
How did you get the state's attention and getting them to recognize you as a program that was worthy of supporting?
Well, I believe I was not here for the very beginning for that purpose, but this is what I've been told. They threw out into the Tennessee world, um, here's an opportunity for a grant. They identified 4 different areas of Tennessee needing help, and each area consists of 5 counties. They put it out there. We wrote a um, submission. Is it a submission? We were awarded the grant. We were awarded it in 2022. We started services June of 2023 after we had our mobile unit built. And we hit the road running at that point and have continued in those 5 counties. And then our data was sent up when it was time for the grant to end, and the state looked at it. The people that we work with at the state level are fantastic. They put together a great report of all 4 mobile units and the impact that it's had, and we were granted an extension.
And that's good to know too. In Kentucky, there's a couple of things when I'm thinking about state funding and things like that. We're lucky that we have a governor's office of early childhood, so it's a
Mhm.
state appointed. I'm sure. I don't know if Tennessee has it, but I know a few other states do, and so it's an entire government office, state office dedicated to early childhood. And so they've been helpful. Now they don't necessarily award grants and funds, but it's been good to get to connect with them and share information and publicity and names. Another thing that I'm curious to see if y'all are involved in with the Big Beautiful Bill, all that rural impact money that's coming into the states. I know Kentucky got some, I know Tennessee got some. So we're talking with the state about how we can get involved in that rural health money. And I didn't know if that was something that y'all were involved in too.
Um, yes, we are. That is correct. Is that right?
That,
That's where our extension.
yeah, that is something that the state is involved in, and we're sort of receiving through them, but they are looking at several different ways to access that money. Mhm. So I would encourage you to really try to get in there too.
Another question I have, sorry that I'm rapid firing on y'all.
No, 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 no,
Um,
no.
Another question that I think I would like to know, and maybe be helpful for other people, is talking about record keeping and data and stuff like that.
Mhm.
I think the way that we're leaning towards structuring ours is we're going to have like an actual brick and mortar clinic, real small, 1 or 2 rooms, but then the bus is going to be, an extension of that.
Mhm.
Um, and so we know that we're going to have to get like an EHR, and start working with that. I didn't know if there was a certain uniqueness or challenge, of using that with the mobile piece of the program.
Um, for me, so all of our records are on an EHR. Um, and we use a VPN to have the secure EHR while we're out in the community. Um, Finding service, like cell service, internet service, um, might want to look into satellite. We do not have that. We are good with our service in 4 out of our 5 locations. And our fourth one, we went through the cable company and added an internet service, a wireless internet service at the location. It's a great location, and they allowed us to add our own little wireless. So finding um, connectivity is really the biggest issue, and you can work around everything. We have I can't remember the name of it, but it flips in between service providers. I think we have 2 service providers, the little round thing, the top of our bus. And whenever one drops, one picks up. Um, so that's what we do for the other 4.
And then to always be flexible. So to always have paper copies of everything you have on your electronic record as well,
Yes.
because you will need those.
Yeah, I didn't even think about the connectivity piece. I mean, I know that we lose cell service. Um,
Yeah.
and I'm glad to know that it's just a little thing that y'all worked out.
Mhm.
Because when you said satellite, for half a second, I was picturing like the big dish satellite spinning around on top of the
No, but
on
that
top
would
of
be
the bus.
great. What is is it safe? Not SafeLink. Sky, what is
Starlink.
the hmm?
Starlink.
Starlink.
Yes,
We
yes.
did look into that. By the time we looked into that, we had everything else worked out, so we didn't change over. But that's definitely something. Um, do you know where you're going to park your unit?
Well, that was one of my next questions on my list. So thank you.
You're
I was
welcome.
I was curious if when y'all went to places, if y'all picked a spot and people came to you, or
Mhm.
if you went to, I know you don't do house visits, but you know, you traveled to multiple places in a county to get people.
We travel, or when we started, we met with all the head of the counties, um, the movers and shakers of the counties, depending on what county we were in. And we had lunch and learns to explain to the county that we were coming in, and that included medical professionals, behavioral health professionals, elected officials. We're coming in. This is what we're doing. Where do you guys think it would best benefit your county? And it was very county specific. And they told us where they thought that we would best serve them. And so we set up in the town or the area that they suggested.
So do
So
you
in
do?
each county we have one location. So we go to that same location, and we're in 5 counties, so we're in each county one day a week. So every Monday we're in one, every Tuesday we're in another. So everybody knows exactly where we are and when we're there.
Yeah, that makes a lot of sense. Because I was about to ask, do y'all do appointments? Since people know where you are, they come to you,
Mhm.
or do you
Yes,
do walk-ins?
we started with walk-ins. And sometimes we still do walk-ins. If they come in, we try to work them in as best as we possibly can. But now, we're almost 3 years in, and in some of our counties, we have appointments from the time we get there until the time that we leave in the afternoon. So we still take both.
Thinking of too about, I guess I have a staffing question now, and
Mhm.
I want to frame it so that it's not so pediatric focused because I know not everybody is going to go that route. But um, we have a hard time finding independently licensed people to do
Mhm.
services. So I didn't know if y'all how y'all structured your staffing patterns, if you have a independent licensed person on staff and then they supervise, or if you partner with some of the local schools that send their people, things like that.
Our nurse practitioner is licensed. Um, I am licensed. One of the other therapists is licensed. The other one is in the working process, in process of working towards her license. Um, so for our nurse practitioner, she has a supervising physician that she is in contact with. Um, I guess let me back up a little bit. Ridgeview has 5 brick and mortars,
6.
6 brick and mortars. So we refer back to our brick and mortars when possible. We can also we're referred from our brick and mortars, but we have other physicians on staff, other psychiatrists, and also we have a part-time primary care physician as a um, supervising physician for a nurse practitioner.
So the way we were able to actually license our bus is it's sort of connected to our brick and mortar. So we're able to use all of those staff and all of those licensed clinicians as supervisors as well.
Yeah, that makes perfect sense. Um, because we have a nurse practitioner on staff with us, and then me and another staff member, we're also licensed, but we're not independently licensed yet. And so that's been one of the challenges that because we also don't have necessarily the funding to bring on an independently licensed person. And so, um, I mean, the laws allow us to practice as long as we're under supervision.
Mm-hmm.
Still, it makes it a little bit easier if there's a person directly there. And so it makes sense the way that y'all were talking about it. Thank you. Yeah, another question I have, one thing that I'm worried about is differentiating ourselves from a mobile crisis unit.
Mm-hmm.
Because I recognize the importance in that, but I just know right off the bat we're not going to be equipped to be effective. Um, and so I don't know if y'all have that. I mean, I know Ridgeview is probably more established, but I don't know if at one point if y'all had that problem where people were treating y'all like crisis response team, if that's not what y'all were wanting to do.
Right. We have a mobile crisis team at Ridgeview. I don't recall ever really in the 3 years that we've been where people have mistaken us. Um, I think people have come to us in a crisis and we have contacted our crisis unit or our mobile crisis team and we facilitated them meeting and would just do a friendly handover to mobile crisis. Um, Other than that, I don't think that we've ever had anybody like just coming on thinking. We did a lot of advertisement though, like our bus actually says exactly what we do, like on the side with our phone number, um, and so you can when you look at it, it says therapy and med management and primary care. Um, so it's very clearly labeled, and I don't know if that has helped or not.
Do you have any recommendations for what a program can do if they do have someone that comes to the clinic for services and they happen to be in crisis and you do not have you do not have a crisis team built into your
Mhm.
program? Do you have some recommendations or some best practices recommendations?
So in one of the counties that we serve, we are not the mobile crisis over that county. So we have reached out to find out who the mobile crisis is in that county. Introduce yourselves, let them know what you're doing, try to build a relationship with them so that should something occur, you can call them. They know who you are, and you can try to have a warm handoff to them.
One more question that's popped into my head as you were talking, Kim, is I'm curious what your thoughts are on when it comes to having a mobile behavioral unit. Um, one, do the people that you see, is it as effective as if they were coming into a standalone building or home visitation, because we don't ever want to assume that just because it says behavioral health that it works.
Mhm.
And so I was curious if people feel like it's as helpful going to a bus as it is a building. And then the part B of that question would be, I know for physical buildings with that serve behavioral health and mental health people and psychiatric health, there's certain safety features that you want and that you want to make sure that you are keeping mindful of. So how do you reconcile that being in a bus or van or whatever it is, mobile unit that you end up using?
Um, okay, first part of the question. I think it is absolutely, it does work. It is absolutely worth it. We've had a lot of clients. We're a little less intimidating. You're not going into a waiting area sitting with 10, 15, 20 people. Um, you come on, there's five staff there. And by the second time, at least half the staff know who you are. So it's they come in, they're greeted by their first name. Hey, how are you? There's a conversation. They feel very almost like a family like. They it's not walking in to go see your therapist or your nurse practitioner. I mean, you're going to get the services, but it's very relaxed. And I've had quite a few people say that they don't think they could ever go back into a brick and mortar setting just with their anxiety and having to deal with people um, in a closed area. So, yes, I absolutely think it is fantastic. Um, how do we keep the safety aspect? That's a good question.
A lot of it is training and preparation. So, and it's the same as our brick and mortar, honestly, is being able to recognize and de-escalate before we get to a crisis situation. Um, and that's really heavily what we focus on. And then just being aware of, I mean, obviously you're being aware of your exits and all of that sort of safety information. Like Kim said, being aware of the crisis responders, law enforcement, should you need them. But really it's being prepared and being able to de-escalate before we get to that point. And as Kim said too, there's usually only a couple of people present at any given time. We're relatively small. There's like three offices on our RV. So I don't know, Kim, that you've ever had really anything escalate.
we have not, thank goodness. We do have a sign on the inside of our door that says no weapons. And this one gentleman took a step up and he goes, "Oh, got to go to my truck. I'll be right back." And got rid of whatever he had on him. I'm not sure what he had. Um, and then came back in. It was very nice. Our so we have not had any escalation on or even near at the time. I feel like we're pretty lucky in that aspect. Um, Sometimes we're sitting outside, sometimes we're inside, but it's a very small area. It's a 33
33?
foot RV that's been converted. So we have primary care and med management in the back, and it looks like a full doctor's office. You have an exam bed on the wall with the ear and the eye otoscope, maybe. Everybody, you've been had it look in your ears and your eyes. Full in the back, and then up front we have a therapy office, and that's where our chairs turn around, like our driver's chair and the passenger, and they turn around, and um, we see people up there. And then the middle is our reception area. So it's very small. So we've just been very lucky.
Yeah. That's great. I'm glad that y'all haven't had any major incidences. Um,
Yes.
that's interesting how you have it split. Um,
Hmm.
and so you're talking about for the front part, the chairs swivel around and you kind of
Hmm.
use that as the office. So does that mean your staff that are there also drive the bus, or do you have a separate driver for the
Yes.
RV?
We do not have a separate driver. We have our peer support as our driver. She is a full-time driver. Our office coordinator and myself are backup drivers. We are just under the guidelines for needing a CDL. Um, so I think if we had gone any bigger, we would have that would have bumped it up a whole different um, level.
And I guess the last question I have right until somebody talks and I think of another one is I know earlier you had mentioned that y'all did a lot of publicity and the way
Mhm.
that y'all the vibe that you have in the RV that is like more family, like we're a family, we're not provider client type
Mhm.
relationship. Um, so do you feel like that is what's contributed to the growth of that program, or do you think it was all the publicity, like the big signs on the side of it, or commercial, whatever it is,
Yeah.
at the very beginning that kind of kick-started?
I think initially it was probably our publicity, but I think after people started coming, we have a fantastic team. And I know I'm a little biased, but it is a fantastic team. Um, my nurse practitioner has walked across the street at 4-lane highway to get somebody because they were too nervous to come in. Um, we have people going to their house, when they've missed appointments because that's not normal. So I think that people really feel like they're going to put in just as much effort as we are, and we put in a lot of effort. Um, so I think I would attribute a lot of that to the staff. The staff are just fantastic, in my opinion. And if you come to the Mobile Health Care Association National Conference, my entire team will be there. So
Meet them all.
meet them all. They were all there last year. It was that we had. So it'll be
Uh,
exciting.
I'll come up and get their autographs and say,
Yes.
listen, y'all come highly recommended.
Yes.
Tracy and
Oh,
Kim, this is very heavy work that you do. What are some of the things that you do as a team to keep your team bonded, to keep them, feeling a little bit more lighthearted when things feel really heavy?
Um, hmm, what do we do? We haven't,
um, a sense of humor and being
yes,
willing to be goofy.
absolutely.
Our team is goofy.
We're
Um,
we are very goofy. We have an hour drive or a half hour to 2 hours, and most of us ride together on the bus. So we're all traveling together. So it's kind of a time to talk, to decompress. On the way back, it might not be as chatty because we're kind of decompressing. Um, but everybody is so willing to help. If there have been a few times when raised voices have you can kind of hear raised voices, and everybody quiets down just enough to hear if it becomes a problem. Um, we are very goofy. We try to get together and try to eat a meal together at least once a month. Um, but I think when you spend that much time together with everybody, um, you do become your own little family. And, when you spend 40 plus hours a week with these people, you spend more time with them than anybody else probably in your day-to-day life.
and
You do.
that really, oh, I was just going to say that really is part of the interview process too. I mean, we
Yeah.
really, when we interviewed, how are you in confined spaces? How are you, around people? Do you need your own space? Because you really need people that are good, knowing that they're going to be around other people and the same people all
Yes.
day, every day.
And as to how what Tracy said, we said that a lot during the interview process, and we continue. Like you can go outside for a little bit, but you don't have your own space. So you and be mindful of other people. You're going to get aggravated with somebody. It's going to happen. It's normal. It's natural. How are we going to deal with it? And so we have an extra car that follows the bus in case an emergency were to arise for one of the staff. We don't have to stop services for everybody. Um, Sometimes, they go to the gas station to get a drink, and just a 5 minute time alone can help.
Any last final words you would like to share for folks that are contemplating, like Jonas here, starting a behavioral health mobile clinic? Any last parting words of wisdom?
Do it. The need is it is so over the need is so overwhelming. Um, the data will 100% back it up. People, especially in rural areas, and I'm sure just as much in urban, but we deal with rural. They don't have the options. They need options. They need the help. And if you can help just a little bit, do it.
Well, with that, I would like to thank all three of you for joining us for this wonderful conversation today. It was very meaningful and lots of wonderful insights. And Jonas, thank you for coming as someone, as a program that's just trying to get started with your open and honest questions too. They were so wonderful. Thank you to all three of you.
Thank you for having us.
Thank you.
Thank you.